Dr. Karar, over to you.
Thank you, everyone. It's great to meet you all. My name is Syed Karar, and welcome to a sunny, hot afternoon in Kenya. This is not usually the weather around here. It's actually cooler, but these few days have been really, really hot at night with lots of mosquitoes. But all of you will be fine. Don't worry about the mosquitoes. We're here to take care of you. So very quickly, my name is Professor Syed Karar. I am a faculty in the Department of Medicine, and I am board certified in internal medicine and palliative care, and I am completing my boards in October in clinical informatics. So I have 3 boards, and I feel like I'm very old, but that's good. It's always good to keep that mind sharp. And I am also, as Gitonga very rightly said, the senior health informaticist. And my role with my informatics team, who is sitting around here, has been very key to bridge the clinical aspect when we went live with the EHR system, and kind of getting those clinicians who are the main users of the EHR to buy in. And I must pat myself on the back and say we were very successful in doing that. I think our colleagues, Meditech, also appreciated that we had very little resistance from the physicians and the nurses and the other healthcare providers. So congratulations to all. And we're going to be focusing on EHRs in low middle income countries. And we've done a couple of studies looking at that. And I'm going to take a few minutes just to have my colleagues introduce themselves, and then we'll start with the questions. If there's anyone who has questions that they would like me to ask, please share them with the team, and then I will certainly ask those questions for you if we have time. I think we have 40 minutes and 120 questions to go through, so we will try our best to address all those questions. So Harrison, we can start with you.
Good afternoon, ladies and gentlemen. The leadership of the Aga Khan University. It's a pleasure to connect with you all at this DTEA conference. My name is Harrison Muiru from Smart Applications International. We are a health tech provider working closely with the Aga Khan University Hospital, where we provide a communications platform between the patients from insurance companies all the way to the payers, who are the insurance companies themselves, and they use this as an access tool. We are commonly known in the market as Smart, where we are the pioneer innovators of biometric solutions in patient identification and the elimination of fraud in that perspective for insurance companies. So it's a pleasure to be here, and I look forward to good interactions. Thank you.
Sushant?
Hello. Good afternoon, everyone. I'm Dr. Sushant Pillai. I'm the Managing Director for Meditech South Africa. You saw my boss and colleague, Charlotte Jackson, previously. So I'm part of Team Meditech. The last time I met Dr. Karar, he was quite young. He didn't have so much gray hair. That's what an EHR implementation does to you. But yeah, I mean, we've been on the African continent for 42 years. Our wingspan is 16 countries. We work with strategic partners such as Smart. Our focus is about clinical sophistication, patient experience, provider experience, but more importantly, clinical integration.
Mr. Nawab?
Yeah, first, just to say, I mean, thank you so much for, I think I chased you quite a lot. I couldn't get hold of you. I think you were on the holidays, and probably I was traveling. But I think you come with a reputation, and this is the first time I'm meeting him on the stage. Though the moderators, you know, they put the questions on and we prepare. But, you know, what I like is the surprise elements always. When something nice comes up, you're ready to, because what you're talking, you have to talk what you walk. Having said that, I'm Dr. Mulk. I'm the president of the Mulk Health Enterprise. We are across 70 countries. Alhamdulillah, we are one of the largest conglomerate in the Middle East. We are into pharmaceuticals, into telehealth, teleradiology. I represent, I'm a neuroradiologist by profession. I studied in Michigan. I then went to UK. I did my fellowship there. I was the first one to bring teleradiology in 2007 in UAE. I'm still called the pioneer of teleradiology there. So telehealth was kind of my baby project. The only reason I'm here is because of Shakat. He was very gracious to invite me, though I had to disappear to meet a couple of my investors meetings and all. But having said that, I'm so happy to see all the smiling faces, meeting some wonderful people. I think that's what is all about this kind of summits. It's you follow your heart, you follow your passions, and then I think rest of all the success comes by itself. Thank you so much.
Thank you very much. And George Patsis.
Yes. Thank you for inviting me. Yeah, Sushant, it's a pleasure and an honor to be here today with all of you. I have the fortune to be in the I think in this panel because of my experience and exposure in the cybersecurity industry, which I had the privilege to be in from the beginning, literally. When I graduated in 1993 as an engineer from London in UCL, and then did my master's degree in 1994 in Royal Holloway. Information security at the time was more close to science fiction rather than a science fact. And I've been there since the beginning. I worked with many global organizations as Chief Information Security Officer, with Citigroup, with other vendors on the vendor side. And now I lead the Obrela Corporation, a company, an enterprise that protects high-profile clients and global organizations from cyber threats on a real-time basis. We are a very, let's say, dedicated and expert company in analyzing an immense amount of data in order to visualize what's happening on our customers on a real-time basis, and we do provide the option to prevent those cyber threats on a real-time basis as well. So I think in that, from my shoes, it would be great to share my views in today's panel, and it would be an honor to do so. So thank you again, and looking forward to that.
Thank you very much, all of you. It's a pleasure to have you on stage with me, and we look forward to a great discussion. So I'm going to start with a question for Sushant. So Sushant, we did a research study, and can you all see me, or am I showing my back with you? I'm good, okay. So we recently did a study, and as you know, EHRs first got launched in the 1950s, 60s in the United States, and they were mostly geared towards big universities. And then the big companies took over in the 1980s, and Allscripts was one of the biggest EHR companies. And even today in the United States and Canada, about 90% of the hospitals in the United States in the West are fully EHR at an MRAM level of about 6 or 7. So what are some of the foundational needs in Africa for us to go live? And why are we not there? Why are we lagging behind in the continent of Africa? Meditech has been in practice for over 50 years now, right? So what are some of the things that we ought to do to get everyone in Africa there? And the reason I ask this is because if you look at the burden of diseases, right? So for example, hypertension, something that I see in my clinic every time, 60% of hypertensive patients come from Africa, right? Yet in terms of technology, we are always lacking behind. Why is this, and what do we need to move forward?
Sure, Dr. Karar. Good question. So out of the 55 years we've been in existence, 42 years has been servicing LMIC environments, specifically Sub-Saharan Africa and Southeast Asia. And I'll touch on some of the challenges that we have encountered across our markets. And funny enough, when we kickstart an implementation program with our customers, we call it a project kickoff meeting. And we say that you're going on a transformational journey, a EHR transformational journey. And the three things that are the key catalyst for this is people, process, technology. Funny enough that these are also some of the challenges that we see across prospects and customers. And I'll add a fourth piece to that, and that's investment and budgetary constraints. So let's talk about the people part, right? So if you look at North America or a first world country, what's a physician to population ratio per 1,000? We're looking at 3.54 physicians per 1,000. If you're looking at countries in sub-Saharan Africa, we're looking at 0.2, 0.3. That's a big difference. Now, the same applies to nursing, the same applies to pharmacy, the same applies to debtors clerks. Implementing an EHR project is a big lift, is a big lift on many instances, people being one of them. And in Africa, it's not that we take doctors and nurses and we just put them solely, or the customer puts them solely on an EHR project. They do the EHR project plus their day job. You should know that. I mean, that's the reality. And that leads to a significant piece of burnout and just kind of a loss of interest. Investment in people, especially if you're looking at investment in EHR, is a key element. That's the first one. The second one is process. I think Farhana spoke about getting the data out of the EHR. Now, you can get the data out of the EHR if the data is entered into the database or the EHR in a structured way. If it's not structured, you outputting the data will be quite complex. What do I mean by that? Having a defined process, standard operating procedures, clinical governance frameworks, work states, current versus future work states, best in class guidelines, all that is critical because that forms the foundational blueprint of how you're going to build your EHR. We see it quite often across customers where that is lacking. And once that lacks, the entire structure or the foundation starts to collapse. The third piece is the technology piece. The Honorable Cabinet Secretary spoke about the 93% penetration rate of internet, which is fantastic. It's great. But the reality is in sub-Saharan Africa, it's a vast continent. You know, people traverse 20, 25 kilometers to access healthcare. There's still clinics out in the sticks with a Red Cross sign where a nurse is kind of popping out panados. It's a tough climate. Those areas which are dispersed, we still see access to technology as a big challenge. I was at a 650-bed hospital a few weeks back. I won't mention which country in SSA. The hospital was a 650-bed hospital, was running on a 4 meg line. A 4 meg line. I mean, that's scary. That's the reality. The second piece, we heard a lot about cloud compute, which is fantastic. And I do believe the future of healthcare and technology is cloud compute. But cloud compute comes with a price. That is first world pricing versus African pricing. And the conversations that we are having with Google and Jack, the previous speaker, Jack, is how do we make the cost of technology viable for LMIC prospects and countries? So that's the fourth element. And once you start to get these four elements right, you can start to then put together a blueprint of the journey you want to go with respect to EHR.
All right, great. I just got another gray hair now onto my beard. Thanks, Sushant. All right, Harrison, so you guys have a huge company, right? And I think you're present in about 11 countries in Africa.
Yes, we are.
So how have you dealt with the healthcare inequalities to manage all that? What are some of the techniques that you've come up with?
Before I step into that question, you mentioned an interesting fact around what EHRs can deliver. And I'll relate that to what you mentioned on hypertension, because we are seeing from trends based on data generated by EHRs that we have doubled the number of hypertensive cases this quarter in comparison to quarter 1 to 2023. Interesting fact for us to see what kind of insight can come from EHRs to inform timely interventions. But in our 21-year journey across 13 countries in Africa that we are in, we've traversed the entire divide of countries which are way more mature in terms of their healthcare sector adoption of technology to countries which are just coming into the healthcare transformation journey in terms of digitization. And what we've had to do is really contextualize technology to each particular country, because there's not a one-size-fits-all solution across the various countries based on the mix of infrastructural challenges, computer literacy challenges, governance challenges, and other such challenges that unfortunately we find are quite a significant burden in Africa. If you look at countries at, for example, like South Sudan or Somalia, where we have presence, we've had to look at how we can scale down the solution to providing the basics and also looking at elements where we can promote computer literacy, where as digital actors in the space, we not only come to do what we are intending to do by providing the technologies that we provide, but it's also educating and knowledge transfer of the constituent stakeholders across the healthcare value chain, whether it be a clinical officer who's down there in the village, or is it a doctor or an administrator at a healthcare facility. So a lot of the work that has gone through in the early years of adoption of technologies in some of the remote countries that have we have been managed to set up successfully are in actually education, knowledge transfer. The next thing is in hand holding, which is part of the, we can call it a governance process, so that as the different healthcare institutions get into digital transformation, they are guided on the appropriate technologies. And that means that we definitely across that journey have even held hands with healthcare institutions in terms of the infrastructural acquisition, purchase of computers, LAN cabling, and other such things that we consider basic in advanced countries in Africa, like South Africa, Kenya, Uganda, and the like. And with that, then we are able to journey together to actually be able to demonstrate. So in some of the countries where, for example, like in Kenya, we had a very fast turnaround of being able to demonstrate to our constituent country stakeholders. Like here in Aga Khan, we're able to show that the value in terms of efficiency, patient access, etc., is demonstrable within the first 6 months of use. In countries like DRC, South Sudan, Malawi, you're looking at a 24-month, 36-month window of walking the journey. So it really calls for a lot of contextualization of the situational context of a particular country, and then being able to go the extra mile in terms of bringing down technology to the point where it is adaptive and relevant to the stakeholders concerned.
Thanks, Harrison. That's amazing. Dr. Mulk, you know, when COVID struck us in 2019, virtual health became a huge thing. And I think in countries like England, it's still being offered because just of the backlog of patients. Can we offer you a virtual health appointment? So it would be really nice to hear from you, your experience starting this. And I think there's been a lot of challenges kind of doing virtual health in Africa. I think Kenya is quite advanced in regards to other countries in sub-Saharan Africa in terms of our phone usage, our data usage. But like Sushant is saying, those are challenges that we have. It would be nice to hear from you on how we tackle these challenges. What do you see in the next 5 to 10 years in terms of virtual health? How do we pick this up in Kenya, whereby you have someone remotely living in Turkana trying to call me because their blood pressures are high? Because that's not happening currently. And if it's happening to a very little percentage.
I think probably a very pertinent question considering the digital transformation. This is my domain, and I'm at the moment implementing across Africa to start with Zimbabwe. Zimbabwe was my first. I signed the MOU in 2000, I think just before the COVID struck. I think probably COVID was the catalyst for the adoptions of virtual healthcare. You being a doctor, I being in the same space, I realized I think that the acceptance was not happening earlier. People didn't want it that to sit at home and consult over the telephone. You know, it was mostly a telephonic conversation. I think if you really ask telehealth was like on the telephone, you talk to your doctor. Hello, Dr. Said, I got a stomach pain. And, you know, what do you advise me? He says, you go ahead and take some, you know, Buscofen, blah, blah. COVID was catalyst to make a paradigm shift. Probably, I think healthcare is right now going through a very revolutionary aspects now. whatever the statistics which I have got from the European side, from the American side, from the UK side, probably I'm not going to vouch for those numbers, but there's staggering numbers. They say 15 to 25% of the healthcare facilities in the European countries are already adopted telehealth. I'm not talking about electronic health record. This is way back 1950. It started the journey. I think probably a lot of people have incorporated that. Now, this is basically, if you ask me as a doctor, there's two segments to my personality. I'm a doctor, I'm an entrepreneur. As a doctor, I could see where is the space. What would any country, irrespective, whether it's Kenya, it's Zimbabwe, it's Angola, irrespective who we are dealing with, there are only three elements which I personally feel very strongly. One is accessibility to common healthcare physicians, accessible. Number two is your emergency care. Third is critical care. This is how the whole ecosystem runs around. Now, if you ask me, virtual healthcare was only telehealth. So if this whole thing has completely changed now, this only I realized once I started, doing the MOUs with the countries. I am directly with the president of Zimbabwe, His Highness Emerson, the health minister of Angola, Dr. Paul. We went live in Papua New Guinea last month. Alhamdulillah, I think my journey has been very, very satisfactory. For the only reason is I had my own trepidatious, my own reasoning that probably virtual healthcare would not be an ideal tailored solution for any country. It's a hybrid model. Irrespective, you being a doctor, I think that personal touch going to you, that rapport, the element of, the judgment, will never be replaced by AI. It will be never replaced by, irrespective whatever is going to come in future. So I thought the best it would be a fit where it's a hybrid fit. So we got the remote patient monitoring first in place, and that was probably could be one of the game changer, because remote patient monitoring helped me to monitor, let's for a small example, smart ambulances. Now again, you'd be very surprised if you hear this from me. Zimbabwe being such a huge country, a whole of Harare city had only 16 ambulances. That's pretty astonishing news for me. And when there was a stroke, the cerebral stroke, the bleed, they always say, that's your golden hour. You don't respond immediately to a patient in that particular. Millions of your brain cells, I think probably is going to agree with me. There's the damage to your cells. And also, yes, you're going to lose your patient. So it's a pity that you can't reach out to people who need, that's a basic amenity, an ambulance. So we stitched in first the smart ambulance. I just started my journey in a very small steps. I thought probably I'll do everything. I said, listen, I've got a smart hospital, I got virtual hospital, I can do all this. No, it's not going to work. You have to simplify each of them, reach out to what is the element of practicality, what can you do in practical. So I think smart ambulance was one of my major accomplishment, where I feel you're live talking to the doctor and the emergency responder. The ambulance guy, by the time the ambulance reaches to the person who's having a stroke and getting back that patient back to the hospital is another 10, 15 minute drives, plus minus whatever I'm talking about. Forget about the remote. The remote is far off. So this is like matter of life and death. If you can touch anybody's life meaningfully, I really thought that. At this stage of my life, one life saved. I think probably I've made my life worth it. So I started realizing that this, the whole thing, it is a very small component what I have. It's called a Mulk device. It got all the vital signs. You can do the heart rate, you can do the pulse, whatever vital signs you require at that moment to make a judgment. You as a doctor making a judgment. So I think that marriage can never break. I mean, a lot of people ask me, is artificial intelligence going to take over? I said no, because irrespective of whatever it is, only going to augment. I think Sushant said, or somebody said that it's going to only augment the decision making. The data-driven decisions, yes, are good, but always it's left to us to say, listen, this patient required so and so medication. So I think that was my first step. Then second, I would say is a game changer is in my opinion is remote patient monitoring. Where again, I think that's where the artificial intelligence is coming in. The artificial intelligence could be very predictive to say.
And Dr. Mulk, just for the crowd, could you just go over the remote data monitoring? Because I think that might be a new concept for everyone.
Which one?
The remote data monitoring.
Yeah.
How so you have your remote ICU data monitored. If you could just discuss that.
This is actually this could be a game changer for the hospitals too, because what I'm talking about is optimizing the infrastructure of the hospitals, and this is a serious thought for the management. What is optimization means is basically once you get this devices are the mobile devices, they're trying to reduce the workload of your existing doctors. In a way, they're mitigating the shortage. Let's say you have a shortage of intervist, ICU intervist. When you have the systems, it's called the smart monitoring system. Everything can be done online. The doctor is looking at the whole parameters. It's an ICU run somewhere else by a different site instead of having the infrastructure. So your resources are being allotted. And again, I think the hospitals have to notice the cost saving and also the patient influx, because that's a question which you brought me. Why should we be doing this? It starts straight away from the hospitals. The hospitals has to adopt this because I think that's my observations in last 2 or 3 years. We have been traveling very extensively. I've gone to many African countries. I think the scenario doesn't change. If not Kenya, Zambia, or anybody. Yeah, so I think then anything which you would like to add. So I'll quickly end this. End of the day, I think this is a very passionate topic of mine. I can just go on and on. I told Shaukat also, this is something which has to be taken very seriously. It's no more talking about it. It's happening. Earlier, it was futuristic. They used to say artificial intelligence is future. It's happening right now. It's getting implemented. So it's time that you start thinking, what is the right way to go forward? EHR, yes, it's a spoke of a telehealth concept. It's a very small spoke. But then I think this is what is going to happen in future. It's going to be a digital disparity.
Thank you, Dr. Mulk. And I just want to clarify, I just put things into context. So for example, we have a hospital in Kitale that has 5 ICU beds. So the ICU is being managed by nurses, but you have the ICU consultant sitting in Nairobi in his home with the screens looking at all the ICU beds, with all the monitoring, with all the labs, with all the radiology. And this one person is managing 5 ICU beds in Kitale, making decisions based at home. So that's kind of what most of these Western countries are doing now because of lack of resources, because you can't find 5 ICU doctors to cover a hospital. So they do these shifts. And that's also happening for general internal medicine right now.
Very well.
Yeah.
I think you summarize it very well.
So we have very little time. I'm sorry, but I have a very important question for you, George. So when I was training in Orlando, the electronic health system was hacked in Miami, and they asked at that time, I think it was like $20 or $25 million to release that information. And now all this information is stored in the cloud. It's stored everywhere that I don't know where it's stored, and I really don't want to get into the storing. But how real is the security threat with electronic data, and what do we do to mitigate it? Because this has happened multiple times in various countries as well, right? Where people are just threatening to steal your data until you pay a ransom.
Well, it is real. It is very real. I mean, I don't have to say that. It's everywhere in the news. What you hear, what you read is only a fraction of what is happening and what is actually getting into the news, to be honest. A very small fraction, maybe less than 2% of what is going on right now. I'm going to share more data tomorrow during my presentation about this. As far as healthcare is concerned, it's a huge, I would say, segment of importance for cybersecurity, and there are many reasons for that. I would start from defining the healthcare institutions and the healthcare organizations and healthcare in government per se as a critical component of well-being of any government, of any country. It's part of the critical infrastructure, to be honest, and to be precise. And every regulation around the world not only cares about healthcare as a critical component of the country, but also a very indispensable and essential part of the critical infrastructure of the country. In essence, without healthcare, we go out of business, okay? And it's very important also to consider that healthcare is also now becoming part of that digital fabric. It's becoming part of that digital universe. When we put things online, when we automate things, when we engage technology to orchestrate or to streamline things that we were doing with a human or a more a different way, that actually exposes now a bigger part of that infrastructure to more people. In essence, we are actually creating a bigger attack surface. And the bigger the attack surface that we are creating in healthcare, the more exposed we become. It's as simple as that. The more we automate, the more we streamline, the more we use AI, the more we use technology to make more efficient things or things more efficient, the more we expose things. And the bigger the need for protecting that attack surface as well. So opportunity comes with a risk. But I would actually put this on a different way. If it is cost of doing business, literally, the way it has evolved in the world right now, the same way that when you want to provide healthcare services to the people, you want to have hospitals, you need doctors, you need equipment. It's the same thing. When you want to do things online, when you want to automate things, when you want to use technology, you need to invest in protecting that stuff. So it's not whether we want to do or whether we should do it. We must. If we want to do anything online, if we want to use technology, which we do, we need to take care of the cyber issues at the same time. So it is a fact, and everybody is actually working very hard on that. The more you use automation, the more you digitize the information, the more you use digital health records, the more exposed you become. Now, on the other hand, of course, I would say there is no other way. If you need to improve your health care services, okay, so it's a one-way road. So, but it is a fact. There are ways we can protect ourselves. This is why companies like and corporations like Obrela exist. And it is possible, but it requires awareness. It requires the senior management to be aware about what are the risks and what needs to be done. And of course, access to funding.
So George, what are some of the risks in Africa that would be different from the United States or Canada?
There's no risk different from any other country. The probability is different. Probability means how possible is for the Aga Khan Hospital to be a victim of a cyber threat over the next 12 months. That is, based on our intelligence, significantly lower than a respective US hospital. Okay, but if that happens, the impact is exactly the same. You may risk your data be deleted. You may become a victim of ransomware. You may have health issues. To a matter of fact, human life is at stake. we've been performing testing services for healthcare organizations, and we have proved that human life is at stake. We could literally kill patients because we were accessing healthcare records, prescriptions, and we could change that. So the risk is the same. What keeps you behind is that you're not as visible as a US institution. You are not as bad, let's say in quotes, and you're not a target, the same target, the same high profile target like a big US hospital, but that doesn't mean that you are part of that digital fabric, you're part of that digital world, and you are facing the same threats and the same risks.
Oh, that's scary, right?
Yes, it is.
And the reality.
It is. We are, as I said, this is our job. I mean, we are protecting organizations on a 24/7 basis. We are on the phone, providing incident response services and preventing threats from happening on a real-time basis, 24/7, 365. And I can share with you data, use cases, numbers, and you will be shocked.
Yeah, I'm sure I'll be shocked. I'm sure everyone here will be shocked with the data as well. We just have 10 minutes, and I really want to touch an important topic that I know everyone wants me to ask is AI, and I want to hear from all of you. So I want to ask you to keep your answers to 2 minutes, Iram. 1 minute? 1 minute, 1.5. We find a center. 1 minute, she's saying. I just want to know, and my physicians are asking, I know Dr. Mulk has already answered this, that AI will not take our jobs. But what about 10 years from now? Because when I look at Charlotte presenting what AI is doing, and this is just with Google, I mean, it's dictating our notes, it's giving us a differential diagnosis, it's giving us how to treat the patient. Why do you need me? Right? I mean, the only thing I'm going to do is hold your hand and say, have a good day, how are your kids? Right? But we can even train AI to do that.
And smile.
And smile. But we can put a face, an AI face there to smile. So how secure is my job or anyone's job in the next 10 years? George, we'll start with you.
You're asking me from
your opinion. Your opinion is very important. You're the security guy.
Your job in particular, I'm not sure because
what about
you
yours?
look like a very senior person, and from my standpoint, senior persons, people that have the experience, that make decisions, are going to be the last to be replaced, because the decisions are still going to be human to a huge extent, but everything else it's at stake. And I think AI and what is actually happening right now is the biggest disruption in human history, in humankind, since the beginning of our existence. And I would compare that not with the internet. I would not compare that with electricity. I would compare that with the discovery of the will, just to give you the perspective here. And I think that this is exactly why it's so big, is that we cannot predict what's going to happen next. And that's the definition of disruption. So I do not know. I'm sure it's going to change everything, and it's going to change everything radically, but I'm not sure which jobs are going to go first, which opportunities are going to be created, because of course, when something changes, something else is created. But from my standpoint, junior analysts in every job around the world, financial analysts, medical analysts, stock exchange analysts, legal analysts, junior architects, call centers, are already being replaced. I'm already using AI for reviewing contracts, legal contracts, and it returns to me the contract with track changes. If it's a major change, I send that to my lawyer. But if it's just an NDA that someone needs to review, it's already replaced. And that's only in the beginning.
And it's as good as your junior analyst.
Yes, very much so.
Okay.
It's more responsive, more hardworking. No,
Doesn't go on leave.
Doesn't ask for a pay raise. Doesn't go on leave.
Yeah, no.
It's
no
always there when
secrets.
you need him.
Indeed, yeah.
Awesome. Dr. Mulk, what are your thoughts? I know you feel like the personal touch is important, but 10 years from now, I mean, it looks like things are really growing quickly.
Yeah, we both are doctors, so I think no matter how disruptive this technology is, AI, I mean, I think you would completely resonate my thoughts. My son has also got into medical field. I won't have put him in the medical school if I thought his job is at stake. Having said that, I think there's something called the moral compass. There's a consciousness. There's the ethical uh, regulations, which all will come in place sooner or later. We as human beings will not allow the artificial intelligence, uh, whatever you could call it, to overtake our judgment. It could only augment. I still feel very strongly, especially in the medical field. I'm a radiologist, right? The MRIs, the CT scans, everything is right now already being diagnosed and put in front of me saying that, okay, Dr. Mulk, sign it. I still don't sign. For the only reason is my judgment says that I still have to overlook a, a system which is created again by us. It's programmed. So AI is basically, okay, it's a deep learning. You go back and say, it keeps learning what you're talking each moment. At the moment I'm talking, with 1,000 people are listening to me, this is again being interpreted by the AI. Yes, all agreed. But I still feel human beings cannot be replaced in any kind. I mean, okay, this is a different scenarios. You're talking about analysts and all in that segment. I think in the healthcare, they are very important elements where your decision making is still, because you're programmed to take at that moment some calls, which I think artificial intelligence will not take it in the ER room. You agree, you don't agree?
Thank you, Dr. Mulk. Just to let you know that some of the CAT scans and X-rays that you're seeing on the outside are being read by AI currently. So I don't think that's happening in Africa, but I know it's happening in the rest of the world. So it's going on, yeah. So AIs are reading. I think they're getting validated by radiologists, but they're seeing that the reading from the AI and the reading from the radiologist are almost similar, if not better. So it's
pretty
scary.
good. I think pretty good. I think it's just, as I said, it's getting better decision making. Probably the
Correct.
quality of health care
Correct.
is improving, but it's not a replacement.
It's not a replacement. All right, Sushant, give me some good news. Do I have a job in 20 years?
Let me ask you this. When was the last time you went to a bank?
Gosh,
When was the last time you went to a travel agent?
never. I don't even use them anymore.
So here's this, right? So you haven't been to a bank in the last 5, 6, 7 years, right? You haven't been to a travel agent. 100%. That was 10 years back. You're asking me the question, where do you see yourself? Where do you see ourselves in 10 years? I'm not going to talk about AI, but I can tell you one thing. The conference's theme is digital transformation. There's going to be accelerated digital convergence in all forms. Patient experience, consumer experience. It's going to be on all facets of what we do on a day-to-day basis. And, you watched the movie Back to the Future? Michael J. Fox?
1, 2, and 3, right?
No, that's the first one.
Or just the first one? Yeah, I think
so. So that is exactly what it is Back to the
I'm
Future.
not that old, huh? It was in the 1980s.
You sit in the car and you fly 10 years in the future. And it's scary, but it's also exciting. And that's what it is.
Harrison, share your thoughts.
I'm the bearer of bad news. Yes, you'll lose your job if you do your job the same way.
Where is the CEO? I need my contract signed for the next 20 years.
So the future belongs to organizations and people who are able to adapt to take on AI and take on their jobs from an AI reflection. And that's the new future. Unfortunately, we are looking at generations which are coming ahead of us, who will be the next consumers, the next patients, who have higher trust relationships on AI. At Smart, for example, we are embedding AI in claims processing cycles, for example. And that means as a doctor, you will actually get your claims processed by an AI engine, which will affect your revenue as well at the end of the day. So we have got to really internalize that and say, we have to adapt. We cannot do the same thing the same way and expect to survive. So I'm hoping that you'll sign up to that AI course soon. Thank you.
All right. The take-home point, everyone, is start farming from today onwards. Get a small farm, start farming. You're going to be safe for the next 20 years because everything is being taken over by AI. But thank you very much. It was really lovely having you. Let me just make sure there's no question from the audience before we end this session. No, there is no time for questions, but I'm sure they'll love to meet you during the tea break or the dinner, and you can ask them questions. Thank you very much, gentlemen. It was lovely meeting you, and have a lovely stay in Nairobi as well. Thank you again. Thank you.